Our program is about to begin. At this time, we ask that you please silence all cell phones and mobile devices. Thank you. Director for Quality Measurement and Value-Based Initiatives Group Centers for Medicare and Medicaid Services, Dr. Michelle Schreiber.
Good morning. Let's try that again. Good morning. It's very nice to see all of you. Welcome back. You braved the snowstorm in Baltimore and the frigid weather. I have to tell you, I'm from Michigan, and I find it very amusing that the city closes with an inch of snow, or less. It's a pleasure to be here this morning, and we really do welcome all of you back and appreciate that you're here. And do these slides advance? The slides advance? Maybe not. Next one? Nope, back. We're not working well here. There we go. Let's recap just a little bit from yesterday on this first slide, which is basically a Twitter feed of the top words, as you can see. And it was really an exciting day yesterday, so we're going to talk a bit about that. We're going to talk just a little bit about some of the important things that QMVIG, which is the Quality Measurement and Value-Based Incentives Group, is looking to do. And then we have a very exciting rest of the plenary day today. So I am 11 weeks into my new role, and it's a little terrifying standing up in front of all of you, but I am truly delighted to be here. So let me take a moment just to introduce myself to you. I have over 20 years of experience as a primary care physician in the city of Detroit. And so issues of equity, social determinants of health are really very important and near and dear to my heart. As the former chief quality officer of the Henry Ford Health System, I think I implemented all of these programs that I'm now responsible for. And it really is awesome, but I bring a very frontline, real world experience to that, and it's very exciting, both for me and hopefully for CMS. In addition to that, I led Henry Ford's electronic medical record implementation from the clinical standpoint across the whole system. So what I really find interesting is the intersection between quality measures, electronic health records, and really the whole way that we use electronic data to move things forward. So truthfully, this is just a wonderful opportunity to marry the two. But most importantly, I'm a caregiver. This is my 95-year-old mother, and my dogs, by the way. I couldn't leave them out. But I'm a caregiver, and that's really important. I suspect many of you are also. And I wonder, because, you know, my mom's had her fair share of errors in healthcare and in and out of the healthcare system, like when she got Coumadin instead of her sleeping medication. How do people navigate if they don't have a doctor-daughter or a doctor-nurse or somebody in their family who's a healthcare provider? How did the guy who was addicted to opioids yesterday with a PhD working at Hopkins not be able to navigate the system? And that's really what we're here for and what all of our jobs are all about. So let's spend just a moment talking about yesterday. Paul McGann challenged us to do the following things: to make sure that we make a commitment to get something done, and to deliver on that commitment, and to secure the commitments from others. So again, I hope as you continue to go through these next couple of days, this is what you have in mind. In the administrator's talk yesterday, Seema outlined we can't accept the status quo. And I think all of us agree that we can't accept the status quo, and we need to continue to make things better for our patients and for our providers who are on the front lines of delivering care. And that CMS is to focus on 3 objectives. The first is empowering patients, which is extremely important. How do patients, again, navigate the system? How do they make the best informed choices? To focus on results. And finally, to unleash this world of innovation, because I think we're on the brink where we're starting to transform healthcare, especially when you think about what we can do with electronic data, artificial intelligence, how we can transform things going forward. I think it's a very exciting time. I don't know about you, but I thought Travis Reeder was an amazing speaker yesterday. And he highlighted, yeah, I agree. And he really highlighted for us some of the challenges. And obviously, CMS is working on many things around opioids, opioid reduction. And I know that all of you are too. The states, many of them have passed, relatively strict regulations about this. This was true in Michigan. But I thought this was an incredible talk, and we should all remember that going forward. So let me take just a moment talking about what we're going to be doing in CMS with quality measurement and our value-based incentives group. Just a couple of things that hopefully you'll be thinking about as you go through the day and take this home. The first, and Seema and many others have pointed this out, is really to continue and advance the meaningful measures work and reducing burden. It is important, but it's not just about eliminating measures, although that's important. It's also about identifying the gaps of measures and making sure that we are filling those in. It's about aligning measures, both within CMS and all of our programs, from QuimVig, CCSQ, to Medicare, to Medicaid, to CMMI, so across all of our programs, as well as across all payers. And what's very exciting is the work that NQF has picked up again, because this, had begun a few years ago. It's a collaboration between the National Quality Forum, AHIP, America's Health Insurance Plans, and CMS to develop a core set of measures that align across all payers. Because we know one of the burdens is that providers, they have measures coming at them from all different sources. And if we can align that into a unified way, I think that would make it much easier for not only our providers, but for our patients to understand what's important. The continuous ongoing improvements to the value-based programs. We've heard from many stakeholders, American Hospital Association, American Medical Association, America's Essential Hospitals, many specialty societies, about some of the challenges of the value-based programs. The hospital stars programs and how that's constructed. MACRA is difficult for some providers to understand. The meaningful use promoting interoperability standards. And I want you to know that we take all of those stakeholder comments very seriously and are actively working on transforming or at least modifying some of these important value-based programs to adapt to some of those changing needs. So we're doing new models of programs, and hopefully in the next year or two, you'll start seeing some changes there as well. But these programs are important. One of the reasons that I came to CMS is I think these programs have actually engaged stakeholders, hospitals, providers, post-acute care settings in quality improvement even more so than before. And so I hope we don't eliminate them, but we do modify them to make them better. And I'm very excited about some of the changes that I'm seeing. And finally, promoting interoperability and the use of electronic data systems. I did share, I love electronic health records. Even though when I'm in clinic, I swear at myself for how we implemented them and the challenges of them. Nonetheless, I think we all agree that using electronic data sources is the way of the future, and how we can make measures that are faster, more accurate, bidirectional, provide an opportunity for more immediate feedback as opposed to the typical quality measurement system where you see it a year later, and even then the data may be a couple years old. Electronically, we can do things very differently. We can use artificial intelligence for predictions of data. And so I think the future here is very exciting. For any of you who came to our presentation yesterday on the Da Vinci model, that actually is a great partnership between payers and providers and CMS and the electronic health record vendors to actually have bidirectional, almost immediate feedback, especially they're starting with the use case scenario of prior authorization. So that if you're a provider in clinic, you can actually have immediate access to what you need for prior authorization by payer rather than having to sift through long manuals. So I think that the future is really very exciting. Finally, I would say thank you. Thank you to all of you for coming. Thank you for all of the work that you do to promote quality, safety, the best care possible for all Americans. But most importantly, to those of you who are here who are patient advocates, I sincerely thank all of you. We can't do any of this work without always engaging our patients with the voice of the patients, the caregivers, their families, because we are in this as a partnership. Thank you again for being here, and it's my pleasure to turn the podium over next to Calder Lynch, the Senior Counselor and Advisor to the Administrator. Thank you and enjoy the rest of the day.
Please welcome Senior Counselor to the CMS Administrator Centers for Medicare and Medicaid Services, Calder Lynch.
Well, good morning, everyone. It's wonderful to be here with you, and it's my distinct pleasure to be able to welcome you to the second day of the CMS Quality Conference. Yesterday, you had the opportunity to hear from our administrator, Seema Verma, as she outlined her vision for transforming the American healthcare system, as well as some of the strategic initiatives that CMS will undertake over the coming year to help achieve that vision. These efforts, as she outlined, are spanning our entire agency, every program, every office within CMS. And she specifically talked about the important role that Medicaid plays in this effort. And I'm going to talk a little bit more about that, which is the area and subject that's near and dear to my heart as a former Medicaid director, and about how we're working with the Medicaid program to help achieve that vision. And that's important because if you think about it, Medicaid is the single largest program that we administer. It covers 75 million Americans, nearly 35 million children across the entire country. It's more than Medicare and the marketplaces combined. These programs provide coverage for vital healthcare services like behavioral health, funding for rural hospitals, long-term services and supports. They cover millions of our most vulnerable Americans, our nation's children, pregnant women, people with disabilities, our elderly that live in residential settings or receive care in the community. It is a vital safety net program. It's also the primary source of funding for long-term care in our country, which represents about 30% of overall program expenditures. And over half of that is now being delivered, of that funding is now being delivered in the community, in the homes, which is a wonderful achievement that states have worked for many years to get to, because that's the care that individuals want to receive, and it's more cost-effective for the system. And so given the size and the scope of the Medicaid program, it's clear that it must be part of our efforts to control costs and improve quality in the American healthcare system. And we're pleased to be able to share our work with you here at this conference across 17 different sessions that are dedicated to Medicaid and CHIP alone. So let's start by noting that we have been working diligently to deliver on our promise that was outlined early in the administration to commit to greater flexibility for states to be able to design solutions to meet the needs of their beneficiaries, but paired with stronger accountability for producing the results that matter and for ensuring program integrity for the taxpayer dollars that are entrusted to us. Those three things have formed the pillars of our efforts around Medicaid: flexibility, accountability, and integrity. And we've supported states in that regard by supporting their ideas, their solutions to their problems. We've approved community engagement demonstrations. We've fast-tracked our ability to approve substance use disorder demonstrations to expand treatment for individuals. We've proposed key regulatory changes to reduce some of the burden that states have felt from an administrative perspective. And we've paired that with accountability. In 2018, CMS published the first ever federal Medicaid and CHIP scorecard, which brought a new level of transparency and accountability to the program and really helped jumpstart some of our efforts to shine a light on the program's achievements. We are going to continue those efforts in 2019 as we give states even greater flexibility to manage their program, pairing it with even greater accountability as we move toward a more value-based healthcare system. And we'll build on our efforts to strengthen program integrity through updated regulations and through greater oversight. So let's begin with the focus of this conference today, which is quality measurement and improvement. Since 2010, CMS has been working in partnership with states to improve voluntary reporting of the Medicaid and CHIP child and adult core measure sets. This is really the first time in the history of the program, which has been around for 50 years, that we've had a core set of access and quality measures that we have agreed to and that states have reported to us. So now we have information that facilitates true state-to-state comparisons on key health indicators, including primary care, preventive care, maternal health, chronic conditions, and behavioral health care. For those that have worked in and around Medicaid programs, you've probably often heard the adage, if you've seen one Medicaid program, you've seen one Medicaid program. But let's flip that. Let's make it, if you can measure one Medicaid program, you should be able to measure any Medicaid program. And state participation has been growing as we've collected more and more states reporting these measure sets. And that's thanks to the hard work of the team at CMCS in partnership with states. And because of that hard work, we now have 21 states that are reporting more child core measure sets last year than the prior year, with 45 states now reporting more than half of the measures in that set. We've also seen tremendous progress in the adult core measure sets, with 30 states reporting more measures last year than the prior year, including 2 states that are reporting for the first time. Again, this is really thanks to the hard work that our team has put in. Anne Marie Costello from the Children and Adult Health Programs Group and her team have really dedicated to working with states to improve that effort. But these measures provide a critical input into one of our signature accomplishments of 2018 that I mentioned, the Medicaid and CHIP scorecard. And you heard the administrator talk about our plans to build out that effort. And you'll hear more about that throughout this entire conference. The scorecard is bringing an increased level of transparency to the program. And it's also helping us and states align our efforts to drive improvements and increase accountability. In fact, the scorecard has really helped bring greater awareness to the core measure sets and the issues that states are facing with reporting them. And it's put it square on the radar of many Medicaid directors for the first time. And I wanted to really also thank CMCS Deputy Director Deidre Gifford, Karen Llanos, and their team for all of their work in getting the scorecard stood up last year and continuing to build out on it. The first version that we released last summer includes the core measure sets that I mentioned that are voluntarily reported by states, but it also includes measures in other areas like state administrative accountability and federal administrative accountability. And these measures really are reflecting really important parts and aspects of the program. It's the first time that we've put together federal and state administrative performance metrics on areas like how quickly are we processing managed care rate contracts, how quickly are we processing demonstration requests, state plan amendments, and it's really helped drive efforts to make improvements in our customer service to states. And as we work on the next release of the scorecard, we're focused on improving its functionality, giving the public the ability to do things like generate state-to-state comparisons, as well as adding measures across the key pillars, including in areas like cost and program integrity. We're also, through the scorecard, continuing to work on what you've heard a lot about, which is our initiative around meaningful measures. As you heard the administrator discuss, we're making sure that our measurement and our quality reporting isn't adding undue burden to the healthcare system and to states. And so through the scorecard, we'll be making sure that we're collecting and measuring a tailored set of measures that align across our program. So we're not pulling folks in different directions. And we're going to continue to work to make that a work in progress. And while states have made that tremendous progress on their own in reporting the measures, changes passed by Congress do mean that by 2024, states will have to report on the child core measure sets as a mandatory requirement, as well as behavioral health measures in the adult core sets. So you may have already heard in a prior session about how we're working with states to help them meet that requirement in 2 of our mini plenary sessions yesterday. You will hear more about this in a plenary session in just a few minutes about how one state program is using the core measure sets to help achieve their own programmatic goals. But even as our expectations around reporting are increasing, we're working to ease the administrative burden that complying with these activities requires through automation and technology. One of the critical efforts that supports this is around TMSIS. And if you've not heard of TMSIS, it's the Transformed Medicaid Statistical Information System. It's the system in which states report outcome and claim and other data to CMS. And as of last summer, we now, for the first time, have every state, the District of Columbia and Puerto Rico, reporting into TMSIS into CMS. That's a major milestone. And now that we have achieved that, we've turned our attention to ensuring that the data we're receiving is complete and accurate, and that we're doing that by providing states with individualized feedback on their reporting about the quality and completeness of it. So Julie Bond and her team in the Data Systems Group at CMCS are working diligently to determine where states need to reconfigure their systems, make sure that their fields are matching appropriately, that they've captured all the necessary data elements from their systems, from their managed care plans, and they're reporting it according to our standards. And we continue to emphasize to state leaders, including in recent guidance, about the importance of continuing to work to make sure that the TMSIS data they're reporting to us is complete and they're meeting those requirements. Because our federal partners, like the Office of the Inspector General, are already using data in TMSIS in their analysis and reporting. And by the end of this year, we will release the first analytic files from TMSIS to the research community. And we do expect that this will be a continued work in progress. But we think it's a worthwhile investment, not just because the public deserves transparency into the program's outcomes, but because TMSIS and the data we collect will allow us to eliminate and reduce many of the manual reporting requirements that states face today. We believe we'll actually eventually be able to generate core measures directly out of TMSIS data with states not having to put extra effort into it. And we can also eliminate a lot of the manual reports that states are filing with CMS. So it's a worthwhile investment for both of us to continue down those roads. So zooming out for a second, from the outset, the purpose of our quality measures has been to improve care and health outcomes for our beneficiaries. And now with almost 10 years of experience under our belt, we're working with states to collect and report these quality measures. We're looking forward to an increased focus on quality improvement in the coming years. To provide a couple of concrete examples about how we're already starting to use these measures to improve beneficiary outcomes, I want to highlight just a few of the efforts we have underway to address the behavioral health needs of our beneficiaries, including in the opioid crisis. As part of the broader HHS effort to combat the ongoing opioid crisis, in November of 2017, the administration revised its guidance to help states accelerate their ability to expand access to residential treatment services for people with substance use disorder. Specifically, the ability to access 1115 waivers to waive the IMD exclusion as part of a broader commitment to expand access to the full continuum of addiction treatment services. In 2018 alone, that calendar year, we approved 14 of these waivers, bringing the total number of states with that authority to 21. That's a huge achievement. And it's really due to the close collaboration within CMCS between the team led by Mike Nardone in the Disabled and Elderly Health Programs Group and Judith Cash in the State Demonstrations Group. And following that accomplishment, just a few months ago in November of 2018, we issued further guidance to allow states to pursue evidence-based approaches to address their needs of beneficiaries with serious mental illness, including an ability to seek similar IMD waivers. Both of these demonstration opportunities will be supported through monitoring and evaluation protocols that will include the collection of common measures related to access to care, emergency room utilization, readmissions, and overall health achievements. Already, some of the states that we saw adopt these waivers early on, like Virginia, are seeing tremendous improvements in both increases in the number of individuals who are accessing treatment and reductions in opioid-related emergency room visits. And of course, quality of care is about more than just measurement. Medicaid and CHIP are pioneering quality improvement efforts in areas that are important to states and to the nation and to the Americans who rely on the program. One example is where CMS has partnered with states to drive improvements in children's oral health. Dental disease is the most common chronic condition in childhood, and poor oral health can affect a child's nutrition, development, and their ability to succeed in school. Since 2011, the CMS Oral Health Initiative has been focused on driving the nation and each state toward a 10 percentage point improvement in the proportion of children receiving preventive dental care. Since 2011, we have seen successes in states like Florida, which has achieved an 18 percentage point increase in this measure. And we invite you to join our masterclass later this morning, geared toward individuals working in or around Medicaid and CHIP programs on quality improvement. Medicaid and CHIP's efforts are also aligned federally at the federal level with the CDC-led 618 initiative, which focuses attention on proven healthcare and public health interventions to address 6 common and costly health conditions, many of which are captured in core measure sets: maternal health, hypertension control, asthma control, and diabetes prevention. States thinking about how to prioritize quality improvement activities related to the core set and scorecard measures can leverage the work that CDC has done to identify 18 evidence-based interventions that can improve health outcomes and decrease costs. Overall, we are striving to help states align their activities to what we know works to prevent disease, reduce avoidable healthcare spending, and measure what matters in order to drive improvement. Now, we are excited that you will have the opportunity to hear directly from a state Medicaid official about how quality measurement, including the measures that are reported as part of the Medicaid and CHIP core set and the scorecard, are helping to strive towards the state's goals for quality improvement. So I'm pleased to introduce Dr. David Kelly, the Chief Medical Officer for the Pennsylvania Department of Human Services Office of Medical Assistance Programs. He oversees clinical and quality aspects of Pennsylvania's Medicaid program, which provides health benefits to over 2.5 million beneficiaries. Pennsylvania has demonstrated a long-standing commitment to using measurement for accountability and quality improvement. The state was one of 26 states that received a CMS Adult Quality Grant from 2012 to 2015, which provided the states with support to implement quality improvement projects related to behavioral health. As a CHIPper Quality Demonstration Grantee from 2010 to 2016, Pennsylvania focused on driving improvement in the child core set measures and improving electronic health record functionality. Starting this year, they're also participating in the 618 initiative with a focus on diabetes prevention. Please join me in welcoming Dr. Kelly. Thank you.
Please welcome Pennsylvania Department of Human Services, Office of Medical Assistance Programs, Dr. David Kelly.
Thanks for the opportunity to share with you today how the Pennsylvania Department of Human Services uses the pediatric and adult core measures to drive quality improvement. The pediatric and adult core measures reflect the population served in Pennsylvania's Medicaid and CHIP programs: children, pregnant women, individuals living with disabilities, chronic physical and behavioral health conditions, and persons needing long-term support services to live safely within their communities. We serve about 2.9 million individuals, including 1.2 million children and 1.1 million adults in our Health Choices Medicaid managed care program. Over 178,000 in our CHIP program and over 400,000 Medicare and Medicaid dual eligible beneficiaries. We've recently implemented our LTSS managed care program, Community Health Choices, that serves over 200,000 adults over the age of 21. Today, I want to share with you how our department's strategy of using the core set of measures to drive quality improvement. Our quality improvement strategy starts at the top and permeates throughout all of the layers of our organization. Starting at the highest level of executive leadership, we have regular internal meetings with our Secretary, Teresa Miller, that involves all senior staff. Those meetings are focused on key performance indicators, including 10 measures from the pediatric and adult core sets that are also part of the current Medicaid scorecard. However, the department makes use of a broader set of core measures to improve quality. The department believes that public reporting of our quality measures allows all stakeholders to compare our health choices MCO performance. We publicly report the NCQA HEDIS quality set measures as well as most of the adult and pediatric core measure sets annually on our website. And those results are posted for each managed care organization as well as our statewide average for each measure. Additionally, we've developed a consumer report card using core quality measures such as well-child visits, dental access, perinatal visits, controlling blood pressure, diabetes control, and asthma care. They're reported on our website by each health plan for all 5 of our Health Choices regions. We believe public reporting helps to drive quality improvement and helps our beneficiaries make informed decisions about health plan choice. Those same core measures are a key priority of our Health Choices Medicaid managed care organizations. The culture of quality improvement must also start at the top and infiltrate all aspects of our managed care plans' clinical programs. We hold quarterly quality review meetings with the senior leadership of each individual MCO to discuss performance on the core measures. We use those meetings to discuss performance variation, barriers to care, and interventions designed to improve care. We also hold quarterly quality medical director meetings with all 9 of our physical health and 5 behavioral health MCOs attending. Our high-performing managed care plans actually share their best practices with the results of initiatives that have actually worked. Also, we have implemented multiple contractual requirements within our managed care program focused on quality improvement, such as our managed care and provider pay-for-performance programs, the Patient-Centered Medical Home Initiative, and the Community-Based Care Management Program. Within each of these initiatives, the core measure sets have been applied to drive quality improvement. We also require that our managed care plans report key core performance measures by race, ethnicity, and regional variation. I've been asked today to use one of those measures of the core set, controlling blood pressure in adults, as an example of how the department and our managed care plans use this core measure to drive quality improvement. In 2015, Pennsylvania reported a rate of hypertension control of 61%, which has increased in 2017 to 64.3%. But within this data lies important variation. Our MCO performance varies significantly from a low rate of 52% to a high rate of 70%. When measuring hypertension control by race in logistical regression models, African Americans consistently had a lower rate of blood pressure control. We also have seen regional variation within our 5 Health Choices regions, with better blood pressure control in our more rural Northeast compared to the urban Southeast region. For diabetics with hypertension, blood pressure was controlled in 69% in 2017, again with a range variation from our managed care plans between 60% and 82%. So as you can see, there's significant variation of blood pressure control based on race, region, managed care organization, and co-occurring conditions. There also remains a significant percentage of individuals living with less than optimal blood pressure control. How does our state agency partner with our stakeholders to address variation in performance and drive improvement? Today I'll discuss some of the interventions that are being implemented to reduce this variation and improve control. At the department, we've moved beyond the traditional model of quality improvement that in the past is primarily focused on just the medical model. We are now approaching quality improvement with an emphasis on whole person care that includes addressing the social determinants of health. To achieve optimal blood pressure control, a whole person approach is necessary that includes addressing food insecurity, including having proper nutrition, housing security, transportation, and providing social support, to just name a few. To facilitate this whole person approach, we've developed a patient-centered medical home and community-based care management programs that require our MCOs to fund practice and community-based programs that outreach to persons with chronic conditions such as high blood pressure. Those programs provide funding for nurses, pharmacists, social workers, and community health workers at the practice and community level to help individuals achieve health-related goals, including blood pressure control. As mentioned previously, there are both racial and regional disparities that we've identified in our data. Social workers and community health workers with cultural awareness can reach out and work with those individuals living within their unique communities to improve blood pressure control. Our MCOs have also developed innovations to improve blood pressure control, such as dietary counseling that's actually paired with appropriate food delivery to both that individual as well as family members. Telemonitoring of blood pressure, coupled with health coaching, text reminders about follow-up care, and patient incentives for ongoing monitoring to achieve targeted blood pressure goals. Our best performing MCO, mentioned earlier, worked with our health information exchange organization to identify individuals with poor blood pressure control. Armed with that timely information, the MCO care management team reached out to individuals living with hypertension as well as their providers to improve blood pressure control. Increasingly, rapid quality improvement will be driven by electronic health information exchange and electronic quality measurement. Many of our MCOs have implemented the evidence-based interventions for controlling hypertension advocated by the CDC's 618 initiative, such as no or low copays for antihypertensives, 90-day supply of medications, and special packaging for individuals needing medication dispensing assistance. Many of our MCOs internally offer medication therapy monitoring programs aimed at improving blood pressure control. Finally, based on 10 of the core measures, including blood pressure control, our MCO Pay for Performance program places 2% of capitation payment in a quality performance pool for MCOs to earn benchmark and incremental improvement incentives. Those MCOs achieving the NCQA HEDIS 50th, 75th, and 90th percentile benchmark goals earn increasing incentives as they improve the controlling blood pressure measure. MCOs that are below the 50th percentile have offsets deducted from their incentives. MCOs also receive incremental improvement payments based on improving blood pressure control from the previous year's results. This program incents our MCOs to identify reasons for variation in hypertension performance and develop interventions to close those gaps in care. Similarly, the Aligned Provider Pay for Performance program that we've implemented requires our managed care plans to pay provider incentives based on the same 10 core measures. Providers are positively incented to close care gaps, and have patients achieve blood pressure control. In closing, the department has used the pediatric and core measure sets to drive our quality strategy. We've worked with our MCOs, providers, and other stakeholders to develop a culture of quality improvement that has aligned incentives across the health delivery system. We believe quality improvement programs need to be whole person focused. They should develop interventions that provide community-based supports, and they need to leverage electronic health information exchange, as well as public reporting is extremely important so that there is transparency. I've shared interventions we've used to improve blood pressure control today in our population, and we have seen improvement from 2015 of 61% to 64.3% in 2017. But as you can see, there remains a huge opportunity for further improvement. I leave with you today a quote from Benjamin Franklin: "Without continual growth and progress, such words as improvement, achievement, and success have no meaning." Thanks again for the opportunity to share my thoughts with you today. Thank you.
Please welcome the Director of the Medicare-Medicaid Coordination Office at the Center for Medicare and Medicaid Services, Tim Engelhardt.
Thank you, guys. Quick show of hands, really quick. Who is pumped up to talk about dual eligible beneficiaries? Okay. The lights are blinding, so I'll just assume everybody put their hands up. All right. It's a great honor to be here, even to talk about a topic that's going to be tough for a couple seconds. So it's like an honor to share the stage with the others who speak this morning. I particularly want to thank a couple of people for the chance to be here, and it's Kate Goodrich and Jean Moody-Williams, who are great champions for the people that we all serve, and I want to thank them for a second for the great work that they do. But I'm still going to talk about duals. The 12 million people who are on Medicare and Medicaid at the same time, we call them dually eligible beneficiaries, right? And most of you probably know this, right? You also probably know that the vast majority of those people are low-income older adults or people with disabilities. And you also probably know that the vast majority have complex medical and behavioral conditions, and just as importantly, maybe even more importantly, really complex socioeconomic circumstances as well. And it's because of these things that dual eligible beneficiaries, while a minority of the total population in Medicare and Medicaid, account for a disproportionate share of total spending. As Seema Verma noted yesterday, with us in the States, it's about $300 billion every year. It's a population, though, that is it's dangerous to define a group of people by their insurance status, right? So I am the duals guy at CMS, but even I cringe a little bit when we talk about this group because it's diverse in so many ways. Many of you think about them in different categories, right? It's people with physical disabilities or people with intellectual disabilities or serious persistent mental illness. It's older adults, it's people in nursing facilities or people in the community. It's all of these different groups, and I want you to have that mental image as I talk about duals a little bit further today. So while I chafe at the bureaucratic definitions, it's kind of important for us to recognize the really weird roles that Medicare and Medicaid have in kind of shaping the delivery system around us, right? And as you probably know, dual eligibility for Medicare and Medicaid creates this morass of weird incentives and misaligned incentive structures. And one of them is what we call, what economists call this kind of classic wrong pocket problem, right? And so what you can see here is that about 26% of hospitalizations for dually eligible beneficiaries are potentially avoidable, which we should pause on and recognize that's not a great number to begin with. But what you see to the right is who pays for those potentially avoidable hospitalizations, and 96% of it is through the Medicare program. And so if you dream an intervention that involves greater access to community substance use treatment or home and community-based services or the types of care management that's funded through the Medicaid program, yet the savings from improvements are accrued to the Medicare program, you don't have to be an economist to see that there's a wrong pocket dynamic, one that we need to work really hard to overcome. Second, having Medicare and Medicaid at the same time for a beneficiary is is straight confusing, right? You've got multiple ID cards in your pocket, and they all have different 1-800 numbers, and it's hard to tell what's going on at any given point in time. It's confusing for providers, too, right? And to take one manifestation of it, most duals are statutorily protected from being billed any cost-sharing amounts, yet we hear it with great regularity that providers end up sending a bill to those beneficiaries nonetheless. And in part, it's because we've made it really difficult for those of you clinicians in here to actually determine who's in what categories at all the times. I hope some of you know that we made some significant improvements to HETS last year, to the Medicare remittance advice, and to the Medicare summary notice too, to more accurately tell providers and beneficiaries what their rules and protections actually are. And then third, right, despite having not one but two kinds of health insurance, many duals still struggle to access even basic health services that are sufficiently accessible from a physical standpoint, from a linguistic standpoint, geographically or culturally too. So this is a conference about quality, and so I suspect all of you are really familiar with that maxim that every system is perfectly designed to get the results that it gets. In the case of the 12 million people dually eligible for Medicare and Medicaid, though, those results are decidedly suboptimal. A couple of years ago, our colleagues at HHS wrote a report that I think is really profound and important. And in that report, they studied a variety of different Medicare value-based purchasing programs, and they looked at different social risk factors and how they affected our measurement in those value-based purchasing programs. And you can see some of them listed here. And what our colleagues at HHS found, primarily, is I'm going to read it right to you, and it's beneficiaries with social risk factors had worse outcomes on quality measures, regardless of the providers they saw, and dual enrollment status, dual eligibility, was the most powerful predictor of poor outcomes. And that HHS, there's not a surprise there, but that HHS report told us a bunch of things, right? Duals have higher risk-adjusted odds of readmission, higher odds of inpatient admissions for preventable causes, lower rates of preventive health screenings and vaccinations, right? It's no surprise to a lot of you, but some of us researchers in the room, like you can get kind of numb to these things sometime, right? And it's important for us periodically to reflect on the fact that these are not just numbers, right? These are outcomes that rob us of independence in the community. They exacerbate inequities. And sometimes they take from us our loved ones. And the system is perfectly designed to get those results. And that's why ongoing sustained systems change is not just a healthcare challenge, it's a moral imperative. So at this point in time, there's at least somebody in this room who is a jaded skeptic and thinking, this is just, like, there's nothing that we can do about this particular problem. There will always be disparities. And it's just, what can we possibly do, right? And I feel you, okay? But those of us who are optimists, and those of us who are motivated by achieving social justice, there's something in the HHS report for us too, right? And I'm going to read a quote from it. It said, in every setting, be it a hospital, health plan, ACO, physician group, or a facility, there were some providers that served a high proportion of beneficiaries with social risk factors who achieved high levels of performance. This suggests that high performance is feasible with the right strategies and supports. So what's HHS telling us? They're telling us success is possible, even with really tough populations, right? And in fact, So I want to give one example. I want to focus on hospitalizations for nursing facility residents, right? And you see this line graph right here. This is just telling you that over the course of the last several years, hospitalization rates for long-stay nursing facility residents have come down, and come down relatively significantly. This is very exciting, and in fact, what you see in this the most impressive line on this is that the deepest reductions were for avoidable hospitalizations among dually eligible long-term care beneficiaries. So this is great, right? This is progress that we should feel good about, all right? But we concurrently started some targeted interventions where we really tried to address this problem specifically. There's there's like a shamefully high percentage of hospitalizations for this population are potentially avoidable. In fact, we had previously looked at the dual eligible population and found that something like 45% of those hospitalizations were avoidable. And so while the incremental progress is good, we thought we could do even better, right? So we started initiatives in 7 different sites around the country. None of this was like rocket science, right? It was like greater levels of skilled bedside care. It was implementing some communication protocols with physicians. We didn't just achieve like marginal reductions over time, but like enormous declines in the rates of avoidable hospitalizations. And you can see some of the numbers up here. All of these with no detectable changes in mortality or any other unintended adverse consequences. And all of this against a matched comparison group that itself was improving significantly during the same period of time. So the relative rates are great, right? So this tells us that incremental progress is possible, but massive improvement is too. So even in my example, right, this is like a success that I can feel good about, but it only emphasizes that we achieved these results in like a very tiny fraction of the total industry, right? And there's so much further for us to go. And I suspect that everybody in this room could put their finger on some comparable opportunity if we just look hard enough to find it. So Sherry will be coming soon, but not yet. So after all this, we approach our 2019 agenda with more optimism than ever, that reducing disparities and achieving better health outcomes and improving beneficiary and family experiences, these aren't just like the right goals, they're achievable ones too. You hopefully heard Seema Verma yesterday, and she mentioned dual eligible beneficiaries as a priority going into 2019. Our work will focus on 2 big, broad tracks, right? And the first is modernizing the Medicare Savings Program and these archaic ways in which CMS interacts with providers and with states. The fruit of that will be ensuring that beneficiaries never get bills for cost-sharing amounts that they're protected for by federal law. It'll be fixing crossover payments to dramatically reduce burden for providers related to payments and coordination of benefits. It'll be accelerating data exchange between CMS and the states in ways that will improve patient experiences, especially at the pharmacy counter. And it will be generally reducing the pain points for beneficiaries and providers related to billing and eligibility. These are pain points and inefficiencies that for way too long we've accepted as just the price of doing business for this population. 2019 will be a year in which that changed. Second, we'll focus on promoting forms of integrated care in various ways, developing systems in which providers and health plans can take true total cost of care accountability across both Medicare and Medicaid. We've done this for decades now in the programs of all-inclusive care for the elderly. We're doing it now in demonstration programs around the country for which we have increasingly strong evidence base and positive results. We have significant reductions in inpatient admissions in Ohio and in Illinois and Washington State. We have fewer nursing facility placements in a range of states now. We have improving consumer satisfaction scores, and we have systems from coast to coast who are climbing and scratching up the learning curve of true, meaningful, person-centered care. So we're committed to expanding existing opportunities, and we're committed to creating some new ones in 2019 as well. New ways to serve beneficiaries based on their actual needs and preferences and not based on the rules and requirements of 2 different government programs. So there's a lot for CMS to do, right? But I hope that all of you will leave thinking about some things that you can do too. For the clinicians out there, it's okay to start really small. I encourage everybody, please, as a starting point, go back to your practices and make sure that your billing staff are using HETs in the right ways and make sure that they're not sending bills to people who they shouldn't be sending them to. You can't express how important this is, how stressful it is for a beneficiary to know that they have a bill waiting that they cannot pay. So please, I appreciate your attention to that. As referenced earlier by David, Let's all take a close look at our own measures and where we have disparities that we have in our own practices, in our own health plans, in our own states. And I encourage everybody to identify them and then challenge yourselves to address them. And to the states out there, we sent a letter to all of the Medicaid directors just a few weeks ago talking about ways that we could better serve dually eligible beneficiaries. Take a look if you haven't yet. If you've read it and don't know what to make of it, call me up sometime, because Seema Verma and Secretary Azar have made it really clear that this is going to be a year in which we partner like we never have before. And I hope all of you will join me in partnering on that effort. Thanks a lot, guys.
Chief Medical Officer for the Center for Clinical Standards and Quality and Centers for Medicare and Medicaid Services, Dr. Sherry Ling.
Good morning, all. And it's very important for us to all know who we are and why we are here. So I am a geriatrician. I'm also a rheumatologist by training and an internist, and I am also from Honolulu, Hawaii. So please join with me to say aloha. I've always wanted to do that. Aloha. All right. So now that we've gotten that out of the way, I feel better, and that gets me into. I really want to entertain. So I've got Kate and Jean laughing here. I chose this. We crafted this title very carefully, solving the opioid crisis, taking action together. And the reason is that in order to solve a problem, we need to understand it. We need to scratch the surface of what we see to understand the underlying root causes that created this problem, so we don't repeat history. And as Tim mentioned, we really actually need to do this together. Each one of us, and I'm an eternal optimist, has a role to play in understanding this problem and in taking action and solving it. So I wanted to reflect upon, as a clinician, some of what I heard yesterday in Travis's words. And if you will forgive me, I need my readers. We are here to share solutions, best practices, but we're also here to share the stories, to hear the stories, to remember the stories. And Travis's story really resonated with me in a couple ways. Number one, it is so easy to start a drug, right? To write a prescription, it takes no time at all. But it takes effort to understand the history of the symptoms, the person in whom the symptoms are arising. So, that is a call to us as clinicians to really ponder before we write a prescription for an opioid. Is this the solution? Is this the appropriate therapy for this patient at this time? The second point is, let's think about what the patient needs in a comprehensive way. It is not just about the script. And really, what we have here is the crisis in full display that really represents not just overuse and misuse, but it is really a three-headed monster. It is overuse, misuse, pain that we need to manage better, and also mental and behavioral health issues that are just crying out to be addressed. So I think he also said to us, use the evidence, be data-driven. This is just part of the fabric of who you are, so that part will come naturally to you, but we need to work together. And finally, be present for the people that we serve. Be present and make the commitments and be there in their time of need. And I really, really am so remorseful to think about people like Travis who actually found themselves in a very dark place. And so we can together really seek to improve, to strive to solve this problem, but it will take each and every one of us. So what I have for you is depicted here is the problem, the scope of the problem over time, and it really has come to us in 3 waves. In purple is displayed the rise in opioid prescription overdoses. These are deaths due to opioid overuse or misuse. A second that's depicted in orange is the rise that's come from heroin use. Now, one could think on the surface, oh, that's just heroin use, but we need to understand that a significant portion of people who use heroin first misused or overused opioids that were prescribed by our hands. So pulling this together is really important. And the third wave, which one could easily also dismiss, but I don't think we can, is the rise that has come from synthetic opioid overuse. So these are deaths. In 2016, the number rose to 42,000 people, or 116 people per day due to overdose. So in the context of the solution, we as CMS, as part of HHS, are really synthesizing and integrating and fitting in and complementing the 5-point strategy that HHS has put forth to solve this crisis. And the CMS roadmap actually is really playing for CMS to play the role largely as a payer, but payer for value, which means value-driven care, outcome-focused care, meaningfully improving, which is all the nature of the work that you do. And the work that we have focused on, this was released back in 2018 at CMS, is to focus on prevention, treatment, and data. And I ask you to think about these 3 tracks as parallel but interwoven, because our solutions need to be iterative. We are going to learn our way through this if we commit to it. So we have some early successes that we can celebrate together, including coverage policies that now permit access to medication-assisted therapies. We have increased awareness through some of the state Medicaid director letters, through letters informing clinicians about their own practice behaviors. We're using data, making data available for improvement purposes and also tracking, and we are enabling increased access, as Calder mentioned this morning, to not only MAT, but the wraparound services that are so necessary for a sustained effect. And of course, sharing best practices and holding on to those stories that our beneficiaries share with us. So I will walk through some of where we've been and where we are going in these 3 areas, and mentioning first prevention, and then treatment, and then data-focused efforts. So from the prevention standpoint, so prevention of opioid-related deaths. We can think of prevention as preventing substance abuse and opioid overuse and misuse, but we also have to think about how do we save lives and prevent deaths related to opioid overuse. So we also are working on treatment, recognizing that 2 million people suffer from opioid use disorder, and treatment options, including MAT, have gotten to the people who need them about 20% of the time. So the work that you've heard of this morning through Medicaid, through the duals, really is providing the treatments and services needed to effectively manage and save lives of our beneficiaries. Now, importantly, this also includes addressing pain and behavioral health needs effectively. And with the Support Act, we intend to actually address the underlying problems that contribute to this crisis. Now, when you talk about prevention of death, I need to mention that we, as part of HHS, really made a concerted effort to make naloxone readily available through standing orders with pharmacies, providing pharmacists with prescriptive authority, new regulations and policies to make this happen, really so that rescue drugs are available to the people who need them. I will also note that you heard a little bit about the duals and the care that's needed and received by people in long-term care facilities. So co-prescribing of naloxone is a good thing to save lives, but co-prescribing of other agents such as antipsychotics can actually enhance the lethality of any given dose. So again, caution needed. We can use data to prevent overdoses, prevent overuse, but we need to do it together. So there are some prevention policies in Medicaid that Calder referenced, including focusing on reducing the risk of overprescribing as a risk for opioid overuse and misuse, but also noting those multiple pathways to provide non-pharmacologic, comprehensive and integrative pain management, which actually is part of the solution to a sustained benefit of opioid overuse avoidance and prevention. Now, many states have begun to cover complementary and alternative treatments, and we really, there is not going to be a single treatment paradigm that fits for every person, but the flexibility afforded by way of Medicaid is going to permit states to provide what services that their populations need. Likewise, in substance abuse management, now this slide is already outdated, and I heard a higher number than 17, so good job in the Medicaid space. Importantly, this is about one example. Virginia Medicaid demonstration actually already improved access to treatment by increasing reimbursement, a 49% increase in access to treatment services, and a 39% decrease in opioid-related emergency department visits in the first 5 months of the program. So phenomenal progress with focused attention, concerted effort, and a comprehensive approach that is not just about the dose of the drug. So we have 2 new models through the Innovation Center that you heard a little bit about yesterday. The maternal opioid misuse model, which the primary goals are expanding access and service delivery capacity and infrastructure based on state needs, but really can be used to fit and solve the access to care issue for moms and children who suffer from opioid overuse, misuse, and a second model, which is the Integrated Care for Kids, INC model, to achieve outcomes for children and also reducing avoidable inpatient stays and out-of-home placements. And of course, to create sustainable alternative payment models that can really meet the needs of the population at risk. So in Medicare, now while there is no distinct benefit for substance abuse disorder, I actually urge you to look at and understand what currently and already exists. That includes, there's some therapeutics that are available for substance abuse disorder when indicated. There's screening tools that are available to detect who might be at risk of substance abuse disorder, and certainly there are behavioral health services that are available to address the underlying causes or risk factors that contribute to opioid overuse or misuse. And finally, Medicare Part D does cover several drugs that can be used to manage substance abuse disorder, including opioid overuse disorders. And now I need to mention to you that there are also recent policies in the Center for Medicare, in the Part D space that you may have heard of. As of early January, we implemented policies for Part D that included a focus on a 7-day limit for opioid-naive patients, a need for a care coordination edit at the point of sale, where if a prescription for opioids is prescribed by Dr. Rosen, but your primary care physician is actually Dr. Ling, that the pharmacy actually makes a phone call to me to say, hey, did you know that your patient has been prescribed an opioid? And it's just to raise awareness and increase the coordination between us as the care team for our patients. Now, the goal here is really to encourage increased communication amongst healthcare providers. It is also very important to note what this is not. This is not intended to result in the scenario that Travis described, where he had to face a forced taper, right? A non-consensual taper off of opioids. These policies really are about new starts in opioid-naive patients to really call to action the opportunity to consider other therapies beyond opioids. This is all about better pain management as well. So importantly, who is not in the population as a target for this letter are those people who are receiving hospice and end-of-life care services or have palliative care needs. So again, it's very focused attention, but we have become aware that this policy may be misinterpreted, and it's our job to communicate clearly what this policy is and what it is not. And we cannot over-communicate about how this needs to translate into better care and better outcomes for the people that we serve. We have various ways to enhance pain management, a history for a pain history, plans of care, detection of mental health and behavioral health conditions through our Medicare wellness visit. We have payment codes now that provide the ability to take care of complex patients with multiple chronic conditions. There are new flexibilities in the Medicare Advantage programs that permit coverage and access to care and services that are not just a prescription, that may include complementary and alternative approaches. And we are relabeling this to talk about integrated pain care rather than a specific drug or effort. Now, pain management, as effective as it can be, there are gaps in the evidence and there are gaps in the policies that really are dependent on the evidence that comes to us. So HHS actually hosted a comprehensive high-level strategy for pain, as well as a best practices task force, the reports of which are now available and open for public comment. So I really do urge you to look at what is available and also comment where are gaps that have not been detected that are important to note because they matter to the people that you serve. I will also note that CMS recently opened the national coverage analysis in close partnership with our Agency for Healthcare Research to consider acupuncture for chronic low back pain. Now, important to note what this is and what this is not. This is an opening to look at the evidence that applies to the Medicare beneficiary population in the management of chronic back pain. It is not about all acupuncture, it's not about all pain, and it is not a coverage decision in and of itself. This could result in national coverage, it could result in coverage with evidence development if we decide that the evidence that exists is promising but not complete, or it could result in a national non-coverage. So this posting is now also open for public comment. So let me shift a bit into the use of data. We are using data for transparency, to encourage our sharing of information, to understand prescribing practices, and for us to be able to, as clinicians, to be able to reflect on our prescribing practice behaviors. We can use this to monitor the effectiveness of our prevention strategies, of our outreach and treatment strategies, and to support state and local programs. This is one depiction of our access to the data source. What appears on the right hand of the screen is county level data that is actually quite actionable. And finally, when turning back to what our early successes are, I wanted to highlight the best practices. This is you in action, right? That should be attributed, that our successes have to be attributed to. If this is you, this is us, this is the we. Activating over 4,000 hospitals, 120,000 clinicians, 5,000 outpatient settings. We are learning our way through this to solve this crisis. I did want to highlight a couple of approaches. Now, our Quinn QIOs, Anita Thomas yesterday had a session devoted to sharing some of these best practices, including naloxone co-prescribing, supporting MAT uptake, and use of these tools, contributing to over 3,000 opioid-related adverse events avoided over a 3-year period. Phenomenal progress. This is one example of what the data can look like for providers, for clinicians like myself. On the left is a display of the number of days for which opioids were prescribed. In orange would be me, and in blue would be your state. In this case, this is Kansas, Great Plains, providers from the Great Plains. On the right is opioid prescribing over time relative to all prescriptions written. Similar progress and amazing things are happening thank you to our hospital improvement and innovation networks, focusing on better pain management in the hospital, in the perioperative period, really, again, seizing the opportunity to understand and solve risk and overuse in the acute pain space. So, highlighting for you one example, Iowa's Healthcare Collaborative, Compass, HIN. So achieved a 34% improvement in provision of an appropriate pain treatment plan and a 10% decrease in adverse events related to opioids. Now, how did they do this? They encouraged consideration of alternative pain strategies, reframed pain into comfort, and use of standardized protocols. And these protocols are available and shareable. I would be remiss if I didn't mention the Transforming Clinical Practices initiative, partnering with 140,000 clinical practices, working closely together with our colleagues with the CDC, at the CDC on opioid safety. Using evidence-based guidelines, again, at the point of care, instilling those best practices in 20,000 enrolled practices. And again, signaling, you heard from Dr. Sarah Chenard last year about her work in West Virginia. Best practice results over 2 years, 0 opioid-related deaths out of 2,000 patients enrolled in their program. This was about practice redesign and acknowledging the complexities of care that population, her population, the state's population, our population actually needs. And over 4 years, an 86% reduction in opioid prescriptions. Now, we are not only here in Baltimore and DC as central office CMS, but we have our delightful and brilliant colleagues from the regions who they have been at this work for a very, very long time, longer than what I can actually mention here, but building on their work to reduce administrative burden, to actually enhance sepsis detection, all of this. Now, the regional office has created a CMS regional opioid engagement strategy that interconnects various parts of the regional office, and the team is comprised of the chief medical officers who work with providers on understanding and implementing CMS guidelines, pharmacists who review formularies and what is available, Medicare ambassadors who will be reviewing Part D utilization and processes. Our steering committee also receives guidance, central office guidance from our regional colleagues, and all of these people are here today. And for my CMO colleagues, thank you for the work that you do and for being here. Now, what is ahead? The substance use disorder prevention that promotes opioid recovery and treatment for patients and communities act. In short, the Support Act of 2018. Many actions and activities that are called for CMS to lead or contribute to. That includes development and assessment of the quality measure set that can be meaningfully used as meaningful measures in our reporting programs, behavioral health quality measures that still need to be developed, building on home and community-based services, and all of that good work, great opportunities ahead, and perhaps even the creation of a benefit category that will permit payment for SUD and opioid treatment facilities under Medicare. So, before I close, I just want to say thank you from the bottom of my heart for all of the work that you do, that you will do. And as Dennis, Paul, and Janine opened, we are here together, really to make commitments to be part of the solution. And it is my earnest belief that each and every one of us has a piece of this puzzle to solve. So, let's get to work. I want to thank you all for being here, and aloha and mahalo.
That concludes our session. Please be sure to visit the gallery walk between 1:30 and 2:30 this afternoon. Poster presenters will be at their poster boards to engage with meeting attendees. We kindly ask that you please exit the room so that our staff can prepare for the next session. Thank you.